we will get started with session 6B. This is our breakout session on disease and longevity. I'm Dale Hall, Managing Director of Research at the Society of Actuaries, and I'll be moderating today. Probably my main ideas here are we will have potentially an opportunity for questions at the end of the session. We do record these particular sessions because they end up becoming part of the monograph, so I would encourage you, if you have a question, to please try to come to the microphone so we record the question. We can certainly repeat the question back just for clarity if needed. I am pleased to be joined today by two of the writers of our papers on this topic. The first will be Hsin-Chung Wang, who, along with Jack Yu, is writing their paper on chronic disease and longevity risk. That'll be followed then by Sam Gutterman on his paper on understanding multimorbidities. And then we'll have a presentation from Jean-Marc, the discussant for this session, on the two papers, and then have some time, I hope, for some questions and answers from the audience. So with that, I will turn it over to Hsin-Chung Wang.
Thank you, sir. And good morning, everybody. I'm Hsin-Chung Wang. Okay, let's get started. This presentation is about the chronic disease and the longevity risk, and application to type 2 diabetes insurance products. My co-author is Jackie Yu and Zhang. Okay. I will divide this presentation into 6 parts, include motivation, introduction to the Taiwan's National Health Insurance Research Database, diagnosis with type 2 diabetes, exploratory data analysis, and modeling application, and the last is the conclusion. Let's move it to the motivation. First, we see the crisis of population aging in Taiwan. About 89% of older adults have at least one chronic diseases, and the proportion of elderly people with more than 3 chronic diseases was 50%. If we consider health care cost, it's attained to 56% due to chronic diseases. And diabetes is one of the top 3 chronic diseases in the elderly people. So we can also see the idea of diabetes artists 2017. More than 1/3 of diabetes cases are result from aging and population growth. 2018 USRDS annual data report also shows that Taiwan, Japan, and the United States had the highest reported prevalence of treated ESRD in 2016. And in Taiwan, there are 45% of kidney dialysis patients are caused by diabetes. Also, you can see the NCD report. According to the age standardized diabetes prevalence, Taiwan becomes the 3rd highest in East Asia. Now we move to the National Diabetes Studies report of 2017. The percentage of adults with diabetes increasing with age, reaching to 25% among those aged 65 years. But there are 24% of people with diabetes who are undiagnosed. So, and diabetes was the 7th leading cause of death in the United States. Consider the total cost, it attained to $245 billion. And if we see the average medical expenditure among people with diagnosis of diabetes were about 2.3 times higher than expenditure for people without diabetes. So we can also see the hyperglycemia may be regarded as an early symptom of diabetes. They also have 19% to 24% for the elderly. Moving to the death rate of diabetes. The current death rate of diabetes per 100,000 population attained to 40 in 2018. Also, in recent years, life expectancy has continued to grow in Taiwan. It's about 0.25 years of growth annually. We expect that the loss of life and the medical expenses caused by diabetes and its complication will increase the financial burden on the community. So let me move to the introduction of the NHIRD. Taiwan launched a single-payer national health insurance program in 1995. And as for 2018, there are 99.90% of Taiwan population were enrolled. There are approximately 25 million individuals in the register. We use two databases. It's a longitudinal health insurance database 2005 and the elderly longitudinal health insurance database 25. We use inpatient and outpatient claim data set collected during 1996 to 2013. Both data sets are 1 million random sample of Taiwan people, one for group of age 0 to 99, and the other for age 65 to 99 years, accounting for about 44.6% and 45.6% of Taiwan's population. Okay, in this study, we have some research limit. The diabetes-related mortality was so high among the elderly. We should focus our goals on the group of age 45 to 99. Note that data quality, we only use the data for the period 2003 to 2012. We calculate the mortality rate of a diabetic patient according to the criteria of death judgment. Due to the nature of our data, we can only estimate the mortality rates in 2006 to 2011. Let's move to the claims database from 2003 to 2012 were searched to identify any outpatient visit or inpatient admissions with diabetes as one of the diagnoses. Classification 1, patient with type 2 diabetes, but exclude the type 1 diabetic. Classification 2, patient in the classification 1 and who takes the refillable prescription for chronic illness. There are different problems of diabetes prevention and incidence research in previous study, include using interview survey, observation time is too short, insufficient samples, and the different criteria for diabetes identification, and a high proportion of diabetes patients with treatment dropout. We use 1 million large sample to reduce small sample size problem, and by means of conduct exploratory data analysis to elevate if the observation period, the number of outpatient visits, and the diabetes classification definition reduce the problems. So now we move to the EDA. We try many observation periods. That's an example, 1 year, 2 year, or 3 year diabetes-free observation period. We find that the longer the observation period, the lower and the more stable incidence rate. For the underwriting needs, in Taiwan, the insurance only required to submit a 2-year health report. We consider moral holiday and overestimation question, so we choose 2 years as the observation period in this study. We don't fully understand why some people develop type 2 diabetes and the others don't, but it is clear the certain factors increase the risk, include weight, fat distribution, inactivity, family history, and so on. How to confirm the new case of type 2 diabetes and symptoms of hyperglycemia in diabetes may disappear due to weight loss. I don't know. So the prescription drug is often included to decide the diabetes. Unfortunately, they are concerned in data quality of prescription drugs records, and some people may even use diabetic prescription drugs for weight loss. That's according to our consultant with doctors. And the patient may think for alternative treatment. They are 46.7% of diabetes patients using complementary and alternative medicine. So we don't use the prescription drugs in deciding diabetes. In the paper, Lin, 2005, shows that the accuracies of diabetes diagnosis in NHI claims data in Taiwan was 74.6%, and the accuracy of a case with 4 outpatient visits was 96.1%. So the number of outpatient visits was the factor most associated with diagnostic accuracy. So we consider referable prescription, which we say RP, for patients with chronic illness. Okay. Let's see the 4 outpatient visits per year. The 5-year average prevalence of type 2 diabetes increased from 2% to 60%, and then decreased to 6% for women. Incidence rate, we using the criterion for 4 outpatient visits per year and are also very stable. The incidence rate reached a peak 2%, around age 75. The incidence rate based on 4 outpatient visits per year and 1 RP per year are almost identical. It seems that patients with the diabetic RP are likely to have diabetes. Since RP is easy to confirm, so we set the new judge criteria of incidence rate is classification 3. Patient no diabetic claim record in previous 2 years, and who first take RP as the new diabetics. That's we can see the graph, the incidence rate of type 2 diabetes. In the left is 4 outpatient visits. In the right is 1 RP per year. It's almost similar, and they have the 2% around 75 years. In this database, we must use some judgment to find the elderly patients' weather data. We use 5 conditions. Okay. The age-specific mortality rate of elderly diabetes patients, the male mortality rate are higher, and the mortality rates of diabetes patients are much smaller than those of cancer patients. The mortality rates of diabetic patients was similar to those of Taiwan average people. Only the female mortality rates are slightly larger. This result is somewhat different to those of a previous study, where older diabetes patients have a higher mortality. It's because our definition is connected to the willingness of a constant receive medicine, and this patient may have lower mortality rates compared with diabetes patient cannot or choosing not to take a regular medication. This is the graph, the age-specific mortality rate of a diabetes patient versus cancer patient. We find this is the cancer patient, male and female, and the dotted line is a diabetes patient. Taiwan whole data is the dashed line. Okay. Now we move it to the model evaluation. We used the GAPC mortality models, which is for incidence rate and the mortality rates. Because our purpose is to deny insurance product, we don't use the prevalence, so we just find the incidence rate and the mortality rates. We use the Lee-Carter model, ratio and Hamilton model, APC model, CVD model, and the graduation method, the partial SMR. Also, we can combine the graduation method with mortality models. It's shown in two papers, Wang 2018 and Yu 2019. First, we find the incidence rate of the MAPE, mean absolute percentage error. Find age group 45 to 99. We find the APC model, Lee-Carter model, partial SMR, and the partial SMR plus Lee-Carter model are all satisfactory. Fitting result is more than less than 10%. Let's move it single age, but we only consider 45 to 89 years old. Except the CD model, RH, Lee-Carter, and the APC have the best performance. We use the Lee-Carter model to see the annual increment of incidence rate. That's years 2008 to 2013. The annual increment are small for younger group, increase with age, reaching to around 6% at age 85 to 89 years old. The scale of annual increments is worth to pay attention. Male is higher than female. Let's move it to the mortality rates. We find the MAPE is above 5%, and the APC have the best performance. Also, we use the Lee-Carter model to find the annual increment of mortality rates, the years 2006 to 2011. The average annual increments are 3.6% and 1.6% for male and female. If we only consider age 70 to 89, then the annual increment will be more stable, but slightly reduced to 2.5% and 0.6% for male and female. Now we move into the application. It's for the insurance product denied. That's the motivation is a change in lifestyle for modern people, eating well and moving less. So it will increase in sub-health population. The disease pattern change from acute to chronic. So it will increase the duration of illness and medical expenses. So medical testing technology is changing repeatedly. We find that the rate of self-pay medical examination are increasing year by year. In recent years, food crisis and food safety incident in Taiwan. So we conducted to health management business promotion. Now, the insurance product design, we will focus on the basis of for sub-health population. It must be patient's condition is stable, okay? For the underwriting needs and the accuracy of diabetes diagnosis, RP is convenient than for outpatient visit record for policyholder to get the approval document. So we use the RP, and we must free operation period is to reduce the moral hazard. To design the policies for insurance who continue to receive treatment. Let's see the diabetes incidence rate, 2 RP versus 1 RP. The diabetes incidence rate of 2 RP is about 20% less than those of 1 RP. The gap, the mortality 2 RP versus 1 RP is about 7% less than 1 RP. Two cases, we using the refillable prescription for patients with diabetes. We can obtain stable incidence rate and mortality rate. For example, using the 20% incidence rate between 2 RP and 1 RP, or 7% gap for the mortality rates between 2 RP and 1 RP. As the, this is our idea. I think there were many ideas for everybody to deny the insurance product. Our idea is to deny the medical policies with a premium discount. Or you can use a policy with the severe over effect. The gap, 20% and 7%, you can buy the monitor watch cost with encourage exercise to stay healthy or encourage they continue to treatment, okay? And maybe you can use the diabetes option because if the man continue to treatment, the mortality rate is almost near to the Taiwan whole average. So when the insurance is diagnosis with diabetes, instead of receiving a benefit payment, he or she can purchase a new policy using the standardized price rate. Let's move to the conclusion. The incidence rate of it gradually increasing by year. The prevalence of type 2 diabetes patient climbs with age after age 75, but its increase noticed by year. The mortality rate of diabetes changes with a stable pace. For fitting the incidence rate and the mortality rates, the APC model has the smallest MAP errors. And the Lee-Kahneman model is also feasible choice. If we consider those patients who has at least 2-year diabetes-free ovulation period and at least 4 outpatient claims with the diagnosis of diabetes, or one-time RP for chronic disease as the definition of incidence, the diabetes incidence will be most stable. Thank you, that's all.
My topic today is understanding multimorbidities. Before I start, I thought I'd give you a little bit of motivation for why I did some personal research on this topic. This is an area where I've read, you read on U.S. government summary reports about the trend in multimorbidities, and I had no idea what they were talking about. So I thought it would be a really good idea for me to learn. In addition, though, I've had a lot of thoughts about healthy life expectancy, or rather ill-healthy life expectancy. In other words, you see the table of healthy life expectancy, and there's always this residual. And I think it behooves myself and others who are interested in the topic to really try to start understanding that residual amount of period while people are living. The other one is, I remember reading when I was an actuarial student about the multiple impairment studies. Actuaries for many years in the 60s, 70s, and 1980s came up with these really good reports in terms of the impacts of having multiple impairments. And I haven't seen it lately, and it may be produced someplace, but I haven't read it. So I thought, here's another motivation for me to better understand the impacts. Lastly, we always talk about the improvements of mortality rates and the aging of population, but yet the rate of cardiovascular incidence, the rate of diabetes, or at least reported diabetes, isn't dropping as much as the mortality rate. So therefore, there's got to be a lot of people in ill health that are subject to potentially higher mortality from other causes. So what will I cover? First, in order for us to understand it, we've got to understand what it is that we're talking about, the multimorbidities. Second, the prevalence and trends, and the mortality and health consequences. In particular, I'll spend a couple slides on a special case, which is cardiometabolic multimorbidities, and in a very short time on the effect on health care. What are these things? I'll basically read some of these. First of all, the multimorbidities is the simultaneous existence of multiple adverse health conditions, usually long-term chronic conditions. They're usually, as multiple means more than one, but in many cases it's more than 4 or 5 adverse health conditions. The total health effects can differ from the separate, isolated analysis of the individual conditions. And I think that we focus maybe a little too much on the individual condition and the mortality and morbidity effects. In contrast, I was a little confused about the difference between a multimorbidity and a comorbidity. Well, it's fairly straightforward once you get familiar with it. It's the presence of coexisting or additional conditions with reference to the study, the diagnosis, when you're the subject of the study. An example of a study of, let's say, cardiovascular disease with accompanying hypertension or high cholesterol risk. When you have just one of these, or let's say the study of cardiovascular without hypertension, the mortality implications can be different when you have these multiple conditions. This can occur in several different ways, and typically you look at it as trajectory or pathways toward multimorbidities. You can have it based on just random chance, interrelated conditions that occur. You can have two diseases that are the same, are part of the same continuum of health. You can have two diseases that share a common risk factor. For example, you could have obesity that may lead to diabetes or cardiovascular problems or cancers. You can have a situation where the presence of one disease increases the risk of a second disease. And this is a common study. When you analyze the effects of a particular disease, you have with or without. Let's say with or without smoking. And the last one that I mentioned is the two diseases where one disease causes the second disease. In other words, it's the pathway, the approach to disease development. But in bottom line, the conditions can be but are not necessarily related. But when you get to looking at that ill health expectancy, there's several related concepts that you have to recognize. First is what I've just gone over, which is having multimorbidities. The second one is frailty. There's usually the definition of frailty consists of 5 different elements, and I won't go into detail because I don't have time here, but we have a physical weakness, a lack of endurance, an unintentional weight loss, self-reported exhaustion. In other words, I can't make it up these stairs, and a lack of physical activities. I can't really get out of bed at all. The definition of frailty is 3 of those 5 conditions. There's also, just like other things, there's a pre-frailty. That's 1 or 2 conditions. The third is the disability and dependence. Anybody who's been involved in long-term care knows that you've got the activities of daily living, but also relates to at earlier ages, the rate of disability relating to inability to perform work or be employed. And the little picture is just the interrelationship amongst the 3 categories of ill health. Now move into prevalence. What are we really talking about in terms of percentage of population? This is a challenge, and it's a challenge particularly across studies, in that there is often inconsistent categories. There are some categories of 4 conditions, and there are some categories that are of 40 conditions. So therefore, it can be difficult to assess a prevalence or agree upon a prevalence of the existence of a multimorbidity condition. And also there's a dearth of studies. I've seen, in terms of literature, the growth in the studies of multimorbidities, or where multimorbidities is a variable or a factor involved, has been really growing over the last couple of years, I think, with the recognition that this is an area that is of significant importance. The factors usually associated with them, classically, just like any classical study, age, sex, and socioeconomic or sociodemographic status. I give 2 examples in different countries. Usually I go to U.S. because the U.S. has the most data of anybody. Whether they're good or not is another question, but they have a lot of data. This is an area where U.S. is not farther advanced in other countries in terms of availability of statistics. In the Netherlands, you can first of all see the increase by age, and that's just common sense. Over age 75 in the Netherlands, at least 73% of the population have 3 conditions, and 55% have at least 4 conditions. That means somebody over age 75, more than half have at least 4 adverse conditions. So all of a sudden you start realizing that the interaction and interrelationship and causal effects can be significant. In Canada, provided by a study a couple of years ago, a little more age disaggregation, and you can still see the growth, or the one thing you can see in the Canadian table is the fact that the percentage of those with a given level of multimorbidities is increasing, and that you'll see in most studies. In the United States, a couple of things on these graphs, and again, the distinction between age is probably the biggest driver. This gives you some also feel for the relationship between males and females. Moving to the figure on the left, you'll see that this is in relationship to the poverty level. That means the socioeconomic condition. You'll see that those with lower income have a higher degree multimorbidities. This is you'd think that this was expected, but then on the other hand, those individuals with lower income may not go to the doctor as much, and so therefore may not recognize some of these conditions. So my suspicion is that that's even underestimated in terms of the differential between the poverty, a different level of income. And the right, it gives a little bit of indication of a specified by a trend by period, and it also it depends on the condition or conditions or combined conditions, some of the trends involved. This is an interesting way of looking at it. This is data from Scotland of about a decade ago, but I don't think maybe the height of these graphs change, but I think that this gives you an indication of the number of adverse multimorbidity conditions by age. And once you get to the 80s, the percentage is really high in terms of multiple conditions. What are the consequences? Well, first, it's pretty obvious it can affect a person's quality of life, the ability to work in your working years, your employability, disability, ability just to move around, and as well, bottom line, the impact on mortality. It's especially important when these are interrelated conditions because they can be related in a multiplicative fashion, not just an additive fashion. Many healthcare systems, the way we are structured, and this is not just the U.S., this is around the world, almost all healthcare systems are related to delivery of care to individual acute conditions rather than multiple conditions, simultaneous experience and especially long-term chronic conditions. I don't think our healthcare systems are really geared up to look at the holistic individual in terms of all of its conditions. You can tell this because of people who are taking 10, 15, 20 sets of drugs, legal drugs, in terms of being able to treat their conditions. And you've got to say that some of these drugs have interrelationships that may not always be positive. You see on television all these, do not take this drug if you've got this, and that condition. Well, I don't know about you, but if I had one of these conditions, I'd be really confused because treatment is really complex, and my degree of confidence would decrease. And that really relates to the complexities and support needs that are involved. Various studies have reported inconsistent results in terms of the relationship between multimorbidities and mortality. There's been a number of studies that have looked at frailty, dependence, and multimorbidities and to see what's the driving factor involved. And you see that there's inconsistent results. But I'll get in those in a couple minutes. The comparisons, as I've mentioned, can be difficult in terms of trend over time, or particularly between studies. And if the effect of one, and which is a common issue, as you age, as you grow with multiple conditions, the effect of one mortality driver can be reduced. If a mortality driver is reduced or eliminated, what is the effect on the survivors? I think a significant issue for which I don't think we have answers to, but there certainly has to be a relationship in many cases. Some studies, I think I covered the next bullet already, but involving the study of multimorbidities, and I've gotten my last slide if we have time, there are several measurement systems that have been utilized for this purpose. and which is each of them has their advantages and disadvantages. Some of them just take the number of conditions, as I've indicated, in terms of prevalence. Others take into account the types of drugs that are taken for these conditions. And lastly, the severity of each condition. It's not whether you just have diabetes, but it's how extreme is your condition. This is a study from the United Kingdom, from the Biobank database between 2008 and 2015. There's some interesting relationships. This takes into account the pre-frail or frailty and non-frailty. This is the top part. And you can see that as the number of chronic conditions increases, the relativities to the non-frail individual increases. The bottom part, you compare it by age. They're not, particularly when you adjust, or between males and females, you see that it's not as sensitive as you might expect. Iceland, there was a study done a couple of years ago of individuals from Iceland with an average age of 76. That's the more, I was going to say elderly population, but I hesitate to use that anymore. But you can see that combinations of being frail, being dependent on others for care, and multimorbidities, you'll see that there's some different relativities. We don't have time to go into the details, but you can see that the combination of these factors can make your expected mortality worse. An interesting study that was reported that projected mortality as opposed to just reporting historical mortality. And some of these are kind of frightening, that the percentage of those with at least 4 diseases or long-term chronic conditions may double in the next 20 years. 2/3 of those with at least 4 of those diseases will suffer from a mental health condition. So far I've alluded to mostly physical conditions. Well, when you bring into the consideration mental conditions as well, whether or not you talk about dementia or other, for example, depression, you get almost a different viewpoint in terms of mortality prospects. A longer, just like a lot of other conditions, the longer the period of time with multimorbidity, you would expect to contribute to increased death, mortality rates. Here are some of the leading disease prevalences and projections. I won't read them, but you'll see that some of the leading ones are arthritis and hypertension. Now for a couple slides, just talk about I think of the important cardiometabolic multimorbidities. And I think this is a particularly important combination. It's usually defined, and I say most studies define or include these 3 factors: the type 2 diabetes, coronary heart disease, and stroke. Each combination has been associated with more than just the additive element from each individual item. But one really interesting study that came out, it was a pooling of 16 studies of this in both North America and Europe. The risk of developing a cardiometabolic multimorbidity by those overweight was twice as high. In terms of development, 4.5 times those with class 1 obesity, that is BMI between 30 and 35, and 14.5 times higher with the higher levels of BMI. So that means that those are really the contributing factors. Once you become extremely obese, you are much more likely to suffer from these multimorbidity conditions. It suggests that the primary focus of addressing multimorbidities should be to reduce the number and severity of the risk factors involved. So that means that as society and individuals address some of the basic causes, you'll get a better overall result because you'll reduce the effect of those multiplicative factors. 2 slides before I end on the effect on health. It's a focus on one stage of the health trajectory. Patterns can overlook the changing role of these risk factors in the development, progression, and outcome of the whole set, whether you're looking at cardiovascular, cardiometabolic, or any multimorbidity condition. The existence of these multimorbidities can significantly affect both mortality and morbidity. And sometimes you emphasize the morbidity aspects, the healthcare, the disability costs, or the increasing likelihood of becoming frail. In the United States, those in their 60s, it's kind of shocking to me, take an average of 15 prescription drugs a year to combat multimorbidities. I remember going into my father's, luckily he lived to 100, so I guess that was effective. But in his upper 90s, I think that the doctors poured on the medicine when he hit 95 or 96. But it's difficult to avoid side effects from these multi-medicine regimes. In the U.S., in terms of healthcare spending, those who are involved in Medicare, the left-hand side is the percentage of beneficiaries with these multiple conditions, and you can see the cost of having multiple conditions just skyrocket in terms of the percentage of total. So that means you've got, when we say that the small percentage of individuals contribute to the highest percentage of healthcare costs, well, this is clearly a reason, because the increased likelihood of needing hospitalization just really increases a lot when you have these multiple conditions. Conclusions. One, I think that the enhanced understanding, recognition, and measurement of the existence and effects of multimorbidities, I think, will become increasingly important as we continue to make strides in terms of increasing longevity. I think you'll have an increasing percentage of individuals at older ages that suffer from multimorbidities, and therefore it's going to be be importance in terms of studying medical treatment, as well as the effect on actuaries in terms of studying healthcare costs and mortality. I think that the interrelationship of these conditions will become more important as well, in terms of if we solve the problem of one type of cancer, both one of these other conditions that are affecting the same individuals may even increase over time. And I think that a lot of this is due to the deterioration of the immune system. That's something that's really difficult to recover from. The epidemiology of multiple chronic conditions, whether or not they're in the same trajectory or independent, I think remains inadequately understood. I think there's improvements, and there will continue to be improvements. But I think that this is an area where further research is needed. Because of its high prevalence, especially as you saw early on in the presentation of ages over 75, it points to the problems of current medicine and the organization of delivery of healthcare services. I'm really glad that I think it's an understaffed area, geriatric medicine, who treat who have more experience with these multiple conditions. And I think that will become increasingly important. And I'm a little concerned about the supply of medical staff who really understands these relationships. But But it can also result in uncertainty at different levels during the care process, particularly as actuaries are involved, and as well as medical professionals. It's a major contributor to the heterogeneity involved and the uncertainty involved as we go forward. But information regarding multimorbidities, I think, in the future can help actuaries identify the upcoming health risks of, I think, population segments. I'm just going to, here's just a listing of morbidity metrics that are used. Age, as you can see, as being really important in terms of the accumulation of these conditions. And these are, some of these are publicly available. Some of them are you can buy software to utilize and report and to understand the conditions. Some are involved in terms of illnesses. Some of them have factors involved in terms of the severity of the particular condition involved, and some of them have of an effect on your based on medical records of the individuals. With that, I include the references in the presentation, and obviously the paper has even more references. I think bottom line is this is an area that actuaries should become more familiar with or refamiliarize ourselves with, and catching up on some of the things that actuaries used to do, whether it be through the Framingham study or through other sources. At least our knowledge base should increase, and hopefully mine will as well. Thank you.
Okay, we'll flip to discussion with Jean-Marc. Okay.
Well, thank you for the opportunity to discuss those two papers. I'll discuss them in the order they were presented. So on the Wang and Yu papers, I think it's important to understand that critical illness policies are very big in Asia, and I think they have a lot of merit also to be expanded in other countries. I know they have some traction in Canada. And from a chronic condition perspective, diabetes is a good condition to study, as it's the gateway condition to, as Sam explained, and the multimorbidities as well, in many other more impactful on mortality conditions like heart attack. Wang and Yu had the same problems that is common for those kind of chronic condition is what is the definition of the disease. And I think that's unavoidable. They used data analytics and a modeling method to resolve some of those questions. They had good data thanks to the quality of the participation in the healthcare system in Taiwan. It might be more difficult to get in others. But having some solid definitions is always the challenge. And it's this challenge as well for what is a multimorbidity, or who suffers from multimorbidity. So those are really important to understand. I think that the analysis on the stability of the measure, I think, was a good idea. Using mortality models like Lee Carter and the CBD models for a chronic disease, I think, was novel, and it was interesting that some of them worked pretty well as well. Another nugget, I think, of interest in there as well, beyond the topic of diabetes, is the approach of the partial SMR to smooth when you don't have enough data with a set that has more data. I think it's a very useful technique for a lot of other applications beyond that. The advantage of looking at this disease through, I guess, a data analytics eye was it offers a lot of insight, I think it did to me, on how to approach product development, not from a traditional way we develop products, but from using more data analytics tools. In particular, there is a chart in there where you see the incidence rates vary by age, because not by age, by year, because of the putting in place of the program. If you don't pay attention to your data, you might have that all averaged out, and suddenly you have artificial effects in there. So that's a good example, practical example of those techniques and how they can benefit actuaries. So importance of looking at time series engineered data especially as definition change, as public perception and doctors' perception change for disease. There's a lot of noise here that adds up to the underlying prevalence or incidence that you need to be aware of, and that's highlighted by looking at the time series. A couple of comments that I had beyond that is the results on the mortality, especially for male Taiwanese diabetes patient, is pretty contrary to the medical literature in general. So that might be a definitional issue. I think Hsin-Chung mentioned the fact that the people that do get that refillable prescriptions are probably the ones that are better treated, and treatment is key, and adherence to treatment is key for diabetes control. So those are some of the things that you need to be aware of when you choose the definition of the product. The second thing is Taiwan is really the best case scenario from a data completeness perspective. We would be hard-pressed to get anything close to that kind of data in the US. I'm not so sure about other countries. So that, that allows you to use technique that we could not use here. Issues of gaming the definition is always important in chronic illness, critical illness products. And that's the difficulty of having a fractured healthcare system like we have in the US on how do you have the requisite number of visits to get the trigger. So, and how you would get that. I'm pretty sure that if I tell my doctor I think I have diabetes, I'll get a diabetes code on my medical history right there. And because he can get a better reimbursement for that. So there's issues with this kind of definition, and making that more anti-gameable might be a challenge. I liked, which I had not noticed in the paper, the suggestion about the benefit of the diabetes policy really being a way to expand your life insurance benefit at standard rate. I thought that was interesting as a concept. That it triggers not just a payout, but helps you deal with the fact that you're now substandard. So I guess it's substandard insurance from that perspective. So I thought that it was an interesting paper, and thank you for sharing that with us. Sam Gutterman's paper was a very thorough and quick overview. It's a fairly easy read, so I suggest that to everybody. Because I think sometimes we get buried in mortality overall numbers. But with what's happening with mortality improvement, I think there's been a lot more sexiness in studying causes of death, and understanding multiple morbidities is a really key component of that. So anything that helps actuaries understand that a little bit better is welcome, and so is this paper. And I'm sorry to say there's no multimorbidity study. The last one I saw was just published as a book. Paper book, so that gives you an idea of how long that was. I needed to clarify that, what a book was. Our underwriting manual are mostly based on the presumptions that things are additive. Now, of course, there's corrections when there's obvious violation of that. But it is the underlying thinking, and it's good for us to reflect that it's just one of the things, but many conditions have cumulative multiplicative effects. And especially when you look at older age mortality, that becomes a very critical component. Sam also suffered from the same definitional issue that Hsin-Chung had to worry about, that it is hard to define multimorbidity. It's hard to find studies with consistent definition, and therefore to put a measurement on what it is. I like the little Venn diagram that Sam had. I don't know if I can go back to that. If I can see the page up. Here, the little Venn diagram in the corner. It's a really important concept, especially for elderly underwriting. But I think Sam's paper opened my eye that it is also an issue for younger ages as well. Not in the same proportion, and it's not as critical, but for those people that have multimorbidity at a young age, the consequences are quite important. I found a Belgian study, which I forgot to bring, that had the exact same Venn diagram. So that's a Belgian studies of 85 plus people. The multimorbidity circle is 75% of the people. The frailty circle was about 20. The disability circle was about 35. And the middle intersection was about 5%. It doesn't appear as a big number, even for 85 plus people, but it has a significant impact on the mortality. So that's something to know about. As Sam mentioned as well in his presentation, more and more people are successfully treated from things that would normally kill them and now carry the burden of a past heart attack or a past stroke for many years in life. What are the consequences of that to mortality is not well understood. I think it was discussed yesterday that if you prevent the root cause of a disease, you get lower mortality. But if you treat the disease successfully, you get a more vulnerable population with a higher mortality afterwards. So there's something to keep in mind when we talk about mortality improvement and study that. I mentioned the importance of the validity of that concept into younger ages, and Sam pointing that out. Also in the younger ages, the kind of multimorbidities are quite different, and the importance of mental factors mental illness become very important as well. So it's a different type of multimorbidity that I think was good for Sam to point out. The impact of multimorbidity by income or by socioeconomic status is an important driver on why those mortalities are also different by socioeconomic status. So that was also, I think, an important point that Sam mentioned. Polypharmacy as a measure of morbidity, and then it goes back to Hsin-Chung's paper as well. With prescription checks, we get a lot of information now on prescription instantly. And it would be well for us to start reflecting on multimorbidity when we see the snapshot of the prescriptions that people are taking and the evolution of those prescriptions over the years. And a couple other things is, of course, for increased prevalence as the concept of multimorbidity becomes more and more in the spotlight. There's an issue, and for doctors as well, and the issue of polypharmacy as well. So control of multiple conditions at the same time in a general practitioner's office. There is an inflation of the prevalence and the incidence of those numbers until people are really establish that in their practice. So it's hard to know. This increased prevalence is partly because of real prevalence increase and partly because of an increased awareness that it is important to document it. Sam points out a lot of dangers of ignoring multimorbidity. He, unfortunately, and given that it's an extremely hard challenge that nobody has successfully done, does not have any real practical solutions to that. So we can really hold him up for that. The goal was an educational paper, and I think it achieves that mission. Just a final caveat is that the portability of multimorbidity studies from countries to countries is something that you have to pay a little bit of attention. Prevalence of conditions and cause of deaths vary a lot by country, so the impact might be different there. And you need to be careful when you port a study from one country, and as we saw, there are not a ton of studies to another country. And access to healthcare plays an important aspect in that as well. Thank you.
Okay, thank you, Jean-Marc. Really interesting papers, good discussion here. We do have about 10 minutes or so where we might be able to field some questions from the audience. I would encourage you, if you have a question or a comment or clarification that you'd like to talk to the authors about, please feel forward to step to the mic. We are recording, so if you can help us with name and affiliation and things like that, that'd be helpful as well. Looks like we have some takers on this. So we will start with Anna.
Good morning, Anna Rappaport. Sam, I particularly love the paper, but I also had very much this feeling of welcome to reality. And you hear about the large number of drugs and the large number of morbidities, but also I'd like to suggest and get your comments back about the potential for thinking about a different aspect of this, but maybe one that the SOA could think about a little bit as well. The multimorbidities raise tremendous issues when you have encounters with a healthcare system. We talked about geriatric medicine. I mean, there's the reality of where you get your normal care and that the people being aware, but there are also things like encounters with an emergency room. And you just think about that and how many risks that involves, and you think about the implications for caregivers. We've done some work about caregiving, and it seems to me that an interesting question, like a comment about thinking about, are there some potentials for the SOA to think about how does the existence of so much multimorbidity, and I think that the reality is it's when you get to a certain point, it's most people. Yeah. How does that think about what are the kinds of information that you need to be able to walk in with so that you don't destroy yourself, that the caregiver needs? Is that represent some potential for the SOA to think about some projects there and some additional research? Sam, I think you've started something big.
I thought we might have mics up here, so Sam, if you have comments, I'd ask you to step to the podium, but...
Just really quickly, the paper itself has a couple of examples of number of encounters, visits to doctors. I think that's all really good points.
Next, Les.
Yeah, thanks, Les Lohman. I found it all very interesting, but I have to observe that we in the insurance industry have probably contributed to some of the problems in discovering these things. And you may recall, if you go back 40 or 50 years, most medical care was probably emergency-based, and so we had this fee-for-service approach to dealing with those issues, and it made a lot of sense. But what has happened is we now have fee-for-service for people who are essentially not emergency patients. They're chronically ill and things of that nature. And so doctors are being paid for services rather than outcomes. And there's less attention to, for example, Sam brought up the multiple prescription issue. To my knowledge, there are no decent scientific studies showing the effects of multiple prescriptions. And each of the prescriptions often, if you look at the black box insert, they have some pretty nasty side effects. And when you combine all those side effects, you're probably not making things better. If a healthy person were to take those prescriptions, they would get sick. And so that it's something that I think needs to be observed, and perhaps we need to change our behaviors on. And then, really I've already mentioned it, we're tending to treat symptoms rather than diseases, and we're ignoring the impacts of a lot of the medicines, the prescriptions used for that. One of my favorite issues is acetaminophen, which really, quite frankly, has no good use. So anyway, thanks.
Additional comments? Maddie?
Hi, I'm mainly going to address the multimorbidity issue and make an unashamed plug for the research that my group is doing in the UK, where we're looking at inequalities in multimorbidity and using a longitudinal sort of database to look at incidence, progression, accumulation, and death. And with the main intention being to look at sort of inequalities in multimorbidity, and what we found is if you look in terms of healthy life expectancy is that there's a social gradient in life expectancy, as we know, by income, but that gradient in terms of multimorbidity exists. And what we find is that people who are affluent live longer, but they also live longer with multimorbidity. People who are deprived have shorter lives, but a higher proportion of their life in multimorbidity, but a smaller number of years in multimorbidity. And if you control by smoking, this whole relationship is attenuated, but it doesn't go away. So my question really, which I'm grappling with, is for the affluent group, multimorbidity is maybe just a natural process of aging. As you get older, you tend to, the underlying aging kicks in and you get more and more diseases. And it really doesn't matter what disease you just get more diseases. While for the deprived group, it might be what the Lancet Commission called a syndemic, which is, interaction between your biological processes and the social vulnerabilities that you have, which interact to and we found this, that people with similar accumulation of conditions who are affluent or deprived, the one group lives longer and their rate of accumulation is slower, while for the deprived group, the onset is earlier and the rate of accumulation is much faster. So there is something else other than just the disease process. There may be something added by the social environment, which is really causing this faster accumulation. And the other comments that I'd like to make is that, defining multimorbidity is a big challenge, and it depends on, there are 10,000 diseases, basically, and it's the selection of which conditions you include in your definition of 2 or more chronic diseases, when you count them up, that really matter. And including hypertension means that about 60-70% of people at a certain age have hypertension, so they've already got one morbid condition. So it's this balance between, reaching a ceiling effect very early on in the age prevalence chart. So in terms of deciding what disease to include in multimorbidity or not. So we use this linked electronic health records, which is very similar to the Taiwanese case, where you track people from when they're healthy without any of the selected conditions right up to death, and look at the accumulation, because you have the hospital records, you have the general practice records, and you have obviously the linked mortality records. So and of course the Academy of Medical Sciences in the UK have published a really good report, a review of multimorbidity, which I'd like the audience to look at if possible. Thank you.
Yeah, and I'm gonna bring up this slide again because I think Maddie's points are helpful. So Sam, maybe I have some comments or responses, but also I think it's a socioeconomic sort of slide on the bottom left here that starts to describe, if I'm understanding it right, where people stand on poverty level, or is that, am I interpreting your graph on the bottom left here correctly?
That's correct, and I think that there's the question of existence of these conditions as well as the reported conditions that can be very different. I know studying diabetes several years ago, there was a significant increase of the rate of diabetes, but some of that is just because of more public recognition of the existence, and therefore there's more inquiry from the physicians, et cetera. I just want to emphasize one point. It's in some cases it's the cumulative period over which you have these long-term conditions that are almost as significant as whether you have them at all. So I appreciate your point that you made.
Hi, Erwin Tan, AARP. I'm actually a geriatrician, and I want to thank you for the presentation on multimorbidity and also, disease and longevity. I think one of the things that geriatricians try to do is align patient goals, patient-derived goals with care, and sometimes that also includes thinking about one's life expectancy. I think that's very relevant. For example, prevention is definitely the most important piece of medical care, but at the same time, as one's life expectancy shortens, there are many preventive tests, such as cancer tests, that may diagnose you with a cancer that you would die with rather than because of. And that's one of the things that we try to do in geriatrics, is try to identify when tests are appropriate. In a similar way, especially given in the United States how medical care is often siloed with different providers, the issue of polypharmacy also comes up. And one of the things that's emerged is this idea of de-prescribing. A lot of focus has come from Canada, as well as Johns Hopkins and UCSF. And it's a new idea that at a certain time, people's entire medication regime should be evaluated, and to identify which are appropriate with your goals and your life stage, and to contemplate also how one reduces one's prescription lists as one ages and one's goals and medical conditions change.
Yeah, very helpful. We probably have time for maybe one more question here. So
it's just a quick comment. Al Klein, Sam, great job, overview of comorbidities. I think the next step for us as actuaries is to look at the mortality related to them, because with different comorbidities, they might be additive, multiplicative, a lot of differences between them. So I think that's the next step for us beyond what you've done.
Okay, great session. Many thanks to our speakers and to our discussants. Please join me in thanking them for their efforts here. Thank you very much.